Good afternoon, everyone. So, as you're all digesting your lunch, I thought I would talk about statistics. Everybody's favourite topic. And so I'm Associate Director at IDDO, and what I wanted to talk about today is sort of what our purpose is in, at a higher level of, why we do what we do. And a core thing that we do is individual patient data meta-analysis. And the point of this talk is to try and convince you that individual patient data meta-analysis is a very useful tool in some contexts. So this is the mission statement of IDDO. So it's, we want to improve treatment control of infectious diseases via generating evidence that, and this evidence leads to better treatment, better prevention. And this is based on reuse of existing clinical data. So, why are we all, why do we do what we do? Why are we here? And I think, one of the key goals is improving how infectious diseases are treated, how they're prevented. And, the way you can affect change is by changing guidelines, by improving guidelines, and especially in this space, WHO guidelines. So here's an example of work done by Moru in Bangkok, arguably one of the more important contributions kind of Oxford Global Health in general, and a series of trials looking at artesunate versus quinine to treat severe malaria. And via this series of trials, it was shown very convincingly that artesunate is the better treatment. So this is from 2010. So this saves lives in people with severe malaria, and then this fed directly into WHO guideline, which gave a strong recommendation for IV artesunate to treat severe malaria. And this is what we call aggregate meta-analysis. So in a sense, there was this discussion earlier about what is health. Well, in some contexts, especially severe disease, it is death, not death, is quite a simple binary outcome that clearly reducing mortality is important. With some complexities around obviously disability, etc. But here, in a sense, it's a relatively simple question which you can answer robustly via pooling the evidence. And you don't really need the individual patient data here. You just really need to know how many people got treated in each trial and how many died in each arm, and you just add them up. Now, why do we need individual patient data meta-analysis? So this is what kind of IDDO specializes in. And when I was writing this talk, these are 5 reasons that I could think of where individual patient data meta-analysis is useful. And it's really when you're trying to answer slightly more complicated questions. So for instance, there might be a lot of heterogeneity in how you measure health outcomes. When it's not as simple as did you die or did you survive? There might be, complexity in where the treatment works and where it doesn't work, and very clear indicators for why something does work and why it doesn't work. You get these quite complicated questions around what's the optimal dose? Is it 5 milligrams per kilogram? Is it 6, 7? So you have this continuum, and you want to kind of, work out the relationship between the dose and the outcome. And then there's interesting work around having randomized data, which is key for generating evidence, but also including non-randomized data, and then subgroup analysis. So I'm not going to talk about all of these, but I'm just going to go through a few examples with the aim of trying to convince you that this is a useful thing to do. So in what IDDO does, part of its core sort of business is to standardize data to a unique data standard called SDTM. And the reason this is useful is it massively facilitates doing meta-analysis. Because all these different trials were done in different ways, you know, variables are named differently, things are captured differently. They all get standardized to one format, and then you can pool all these trials together and analyze them in one go. And most of the initial work, which is around cleaning and standardization, has been done for you. So that's what we, you know, that's the business. And then how does this then, you know, why is the individual patient data meta-analysis useful? So this is an example. This is a paper that published a few weeks ago in PLOS Medicine. And in this, this was a trial which was a double-blind, placebo-controlled trial of chloroquine and hydroxychloroquine as prophylaxis against COVID-19. And it took over 2 years to actually get this published because COVID isn't really a very interesting topic anymore. And this was quite a large trial, 4,500 health workers who were receiving the drug for 3 months. And it, you know, it looked like actually chloroquine did prevent symptomatic COVID, which was actually quite a big surprise when these data were unblinded. And then, you know, do your standard aggregated data meta-analysis, and you get this quite nice result that, you know, looks like sort of a 15% reduction in symptomatic COVID. Great. So Didier Raoult, Trump, they're all right. Come on. This is, you know, this is quite an amazing result. One difficulty is, well, how do you define symptomatic COVID? And actually, if you look at these different trials, and I'm not, you know, I'm not criticizing this meta-analysis because I did it, so it has to be right. But this is actually a bit more complicated than it looks. So, you know, is symptomatic COVID just clinical symptoms of COVID plus a PCR? Or in some trials, it's seroconversion and, you know, or a mix. And, you know, what's the time frame we're looking over? What's the dose of the drug? And it is actually kind of a more complicated question than this simple aggregated meta-analysis would suggest. And individual patient data meta-analysis allows you to standardize everything and allows you to, you know, do something that answers a more general question, more, you know, precisely posed question. And I can see people laughing. This is actually, this beer is sold in my parents' village in the south of France. So it's completely irrelevant to the talk. But it's, he is a saint in the south of France. But, you know, I think there's clearly some uncertainty around this, and IPD meta-analysis would be useful. Another interesting area, I think, and you know, this really is important for many infectious diseases, is what we call heterogeneity in treatment effect. So you can think of some, you know, usually you think of it in terms of a relative benefit of giving treatment A versus treatment B, or, you know, treatment A versus nothing. And that relative benefit can really vary dependent on some key factors. So for instance, you know, if you have drug resistance, well, that's going to be very different than if you don't have drug resistance. If you have, you know, very high transmission setting for, say, malaria, you know, the benefit of treatment might be very different from a very low transmission setting. Age, which is, you know, proxy for, say, immunity from many infections. And these, you know, dependent on the infection, you will know that these can determine the relative effect of treatment. Now, we've recently started thinking about this intervention called seasonal malaria chemoprevention, which is basically you give small children under 5, you give them treatment doses of antimalarials once a month during the rainy season. In, you know, the word seasonal is in parts of Africa where malaria is seasonally transmitted, so only a few months of the year most of the transmission happens. And there have been multiple randomized trials which showed, you know, very convincingly that this massively reduces the incidence of clinical malaria. So it's about 75% reduction. And this is, you know, in a very particular setting of the Sahel. This went into the WHO guidelines, and, you know, now over 50 million kids are getting this every year. You know, this is a lot of money. It's about 6% of all malaria funding goes towards this. And, you know, these were very well conducted trials, but it's interesting to think about, well, what is the heterogeneity in the benefits? And obviously, you know, there are a few key points which might determine the benefit. So, for instance, is malaria seasonal or not? So, you know, in the Sahel, it's very seasonal. As you go further south, it isn't very seasonal. And also, in these places with high malaria transmission, you know, a 3-month-old is very, very different from a 5-year-old. You know, the 5-year-old's been exposed maybe hundreds of times to, you know, malaria parasites. You know, whereas the 3-month-old is their, you know, their first exposure. So in terms of immunity, it's massive variation. So seasonality, age, and then also drug resistance patterns. And 2 years ago, WHO said, you know, actually, you know, countries in sub-Saharan Africa really like seasonal malaria chemo prevention. So why don't just everyone do it? And actually, forget about geographic restrictions, forget about age, and actually drug resistance probably doesn't matter. And so now this intervention is possibly going to be deployed almost all over, you know, Eastern and Central Africa. And it's very, very unclear whether this works. And I think this is where individual patient data meta-analysis of the existing data could really help. So we've got some funding from GiveWell and Malaria Consortium to do this and to try and work out whether actually this money is being spent correctly. Final point is on this idea of pooling randomized and non-randomized data. So this is work done by IDDO from last year, looking at this drug primaquine, which reduces the risk of recurrence in vivax malaria. And basically what this is trying to do is it's trying to work out what's the relationship between the primaquine dose, you know, going from very low doses of say 2 milligrams per kilogram to quite high doses, and your reduction in recurrent malaria. And actually, you know, this is quite a difficult question because there are, you know, some trials that have randomized between different doses. But actually, most of the variation is variation in weight. So, you know, obviously, if you're 80 kilos, you know, these are fixed dose combinations. If, you know, sorry, fixed doses, tablets. So if you're 80 kilos, you're getting half the amount of drug than if you're 40 kilos. And this is sort of a non-trivial problem of pooling this randomized and this non-randomized data. And we're doing a bit of methodological work in actually how you should do this. So to wrap up, I mean, you know, why is this useful? Well, you know, better characterizing outcomes to better pool trials, understand what factors are driving the efficacy when you have these non-binary interventions. So for instance, dose, duration, you know, this is where you really do need individual patient data, and then adding in observational data. Final point, just there's lots of data at IDDO, and you know, lots of interesting data. It's been standardized. It's there. It's for free. You can request it. Please ask us.